Welcome, medical students, to today's lecture on the fascinating field of endocrinology, specifically focusing on the intricate relationship between endocrine disorders and polycystic kidney disease, PKD. In this comprehensive script, we will explore various aspects of renal endocrinology and PKD and delve into the role of vasoactive hormones, abnormal glucose metabolism, thyroid dysfunction, adrenal insufficiency, polycystic ovary syndrome, PCOS, growth hormone abnormalities, aberrant parathyroid hormone signaling, aldosterone, adipokines, neuroendocrine dysregulation, and growth factors in PKD. So, without any further delay, let us embark on this enlightening journey. Polycystic kidney disease is a hereditary disorder characterized by the formation of multiple cysts in the kidneys. However, it is vital to recognize that PKD not only affects the morphology and functionality of the kidneys but also disrupts the intricate balance of hormones within the renal system. The endocrine functions of the kidneys, such as the production of erythropoietin, renin, and vitamin D, play an essential role in maintaining homeostasis. In PKD, the cystic expansion and the subsequent compression of the renal parenchyma lead to alterations in the production and secretion of these key hormones. This dysregulation can result in anemia, hypertension, and disturbances in calcium and phosphate metabolism. Vasoactive hormones, including vasopressin and endothelin-1, play a crucial role in the progression of PKD. The elevated levels of vasopressin, due to the decreased responsiveness of the cystic epithelium to its inhibitory effects, lead to increased fluid secretion into the cysts, exacerbating cyst growth and enlargement. Similarly, enhanced activity of endothelin-1, a potent vasoconstrictor, contributes to the development of hypertension and promotes fibrotic processes within the cystic kidneys. Understanding these mechanisms is vital for the development of targeted therapies aimed at modulating vasoactive hormone signaling in PKD. Emerging evidence suggests a bidirectional relationship between PKD and abnormal glucose metabolism. Patients with PKD commonly exhibit insulin resistance and impaired glucose tolerance, contributing to an increased risk of developing type 2 diabetes mellitus. Conversely, it has been proposed that aberrant glucose metabolism may potentiate cystogenesis through alterations in cellular signaling pathways. Insights into the molecular mechanisms linking PKD and glucose metabolism abnormalities can aid in the development of novel therapeutic approaches targeting both conditions simultaneously. Thyroid dysfunction, particularly hypothyroidism, has been observed in patients with PKD. The exact mechanisms underlying this association are not completely understood, but it is believed that alterations in thyroid hormone metabolism, transport, and receptor signaling pathways contribute to this endocrine disorder. Thyroid dysfunction in PKD may lead to a wide range of symptoms, including fatigue, weight gain, and cold intolerance. Identifying and managing thyroid abnormalities in PKD patients are essential to optimize their overall health and well-being. Adrenal insufficiency, resulting from impaired adrenal gland function, has been reported in a subset of individuals with PKD. The adrenal cortex, responsible for producing vital hormones such as cortisol and aldosterone, can be affected by cystic expansion and fibrotic changes within the adrenal glands. Adrenal insufficiency in PKD may manifest as fatigue, weight loss, low blood pressure, and electrolyte imbalances. Prompt diagnosis and appropriate hormone replacement therapy are crucial to mitigate the adverse effects of adrenal insufficiency on patients' health. Polycystic ovary syndrome, PCOS, is a common endocrine disorder characterized by hormonal imbalances, ovarian cysts, and insulin resistance. Interestingly, studies have highlighted a potential association between PCOS and PKD, suggesting a shared pathogenesis between these conditions. Hormonal dysregulation, such as elevated androgens, insulin, and anti-Mullerian hormone, AMH, may contribute to the development and progression of both PCOS and PKD. Further research is warranted to elucidate the intricate interplay between these two disorders. Alterations in the growth hormone, GH, axis have been observed in PKD, with both excessive and deficient GH activity reported in different patient cohorts. GH excess in PKD may contribute to accelerated cyst growth and renal dysfunction. Conversely, GH deficiency may impact growth and bone health in affected individuals. The precise mechanisms underlying these abnormalities and the potential therapeutic implications are still being explored. Disruptions in parathyroid hormone, PTH, signaling are commonly observed in PKD patients, leading to abnormalities in calcium and phosphate metabolism. Decreased PTH levels, along with impaired calcium handling by the kidneys, may contribute to the development of renal osteodystrophy, a condition characterized by altered bone mineralization. Understanding the intricate balance between PTH, calcium, and phosphate in PKD is critical for implementing effective treatment strategies and preventing long-term complications. Aldosterone, a hormone primarily involved in regulating sodium and potassium balance, has also been implicated in the pathogenesis of PKD. Dysregulated aldosterone signaling may promote fluid and ion imbalances, leading to hypertension and electrolyte abnormalities in PKD patients. Furthermore, recent studies have suggested a potential link between aldosterone and cyst growth. Further research is required to unravel the complex interplay between aldosterone and cystogenesis in PKD and develop targeted therapeutic interventions. Adipokines, bioactive molecules secreted by adipose tissue, have gained attention for their potential involvement in PKD pathophysiology. Adipokines, such as adiponectin, leptin, and resistin, have been shown to exert various metabolic effects and contribute to the development of insulin resistance, chronic inflammation, and fibrosis. Understanding the role of adipokines in PKD may pave the way for innovative treatment strategies targeting metabolic and inflammatory pathways. Neuroendocrine dysregulation has emerged as a significant component in the complex pathophysiology of PKD. Disruptions in hypothalamic pituitary adrenal and hypothalamic pituitary gonadal axes have been observed in PKD patients, contributing to altered stress responses and reproductive function. Exploring the intricate connections between PKD and neuroendocrine signaling pathways holds promise for unraveling novel therapeutic approaches to mitigate disease progression. The role of growth factors in PKD-associated fibrosis has gained substantial interest in recent research endeavors. Growth factors, including transforming growth factor beta, TGF-beta, platelet-derived growth factor, PDGF, and vascular endothelial growth factor, VEGF, play pivotal roles in promoting extracellular matrix deposition and fibrotic processes within the cystic kidneys. Modulation of these growth factors and their downstream signaling pathways may hold the key to novel therapeutic interventions targeting renal fibrosis in PKD. In conclusion, the intricate relationship between PKD and endocrine dysfunction highlights the complexity of this genetic disorder. Through our exploration of renal endocrinology and PKD, we have examined the significant contributions of vasoactive hormones, abnormal glucose metabolism, thyroid dysfunction, adrenal insufficiency, PCOS, growth hormone abnormalities, aberrant parathyroid hormone signaling, aldosterone, adipokines, neuroendocrine dysregulation, and growth factors in the pathophysiology of this disease. Further research in these areas is crucial to unravel the underlying mechanisms and develop targeted therapies to improve patient outcomes. As aspiring medical professionals, your understanding of these intricate connections will play a pivotal role in the management and treatment of patients with PKD in the future.